give a presentation today on medical family therapy and how you might implement it into your current practice. So, medical family therapy is based in the principles of systems theory and the biopsychosocial spiritual approach. It assumes that all biomedical problems have psychosocial impacts and vice versa. It is also focused on understanding health, loss, trauma, and death within the context of the family and its intersections with systems of care. Medical family therapy seeks to address the intersecting needs of patients, the healthcare system, and families. So as we move through this implementation presentation today, I'll move pretty quickly and talk at a pretty high level about medical family therapy and the implementation strategy. And then I'll take questions at the end. Again, medical family therapy is really focused on breaking down barriers to access and promoting collaborative care. And the primary goals of medical family therapy are agency and communion. What I mean by agency is empowerment of patients as the experts of their own illness story. Communion is really about engaging a support system and promoting healthy relational bonds with those support systems so that patients do not have to suffer alone. The evolution of MedFT has been relatively newer within the grand scheme of the therapy and medical field. It really started to develop within the late 70s and early 80s. Medical family therapy, which is what we call it now, didn't have that term yet at the time, but it was beginning to emerge through collaboration between physicians and family therapists who noticed a gap in between healthcare systems that addressed biological needs and psychosocial health. So the goal was really to start to address this divergence and bridge the gap. Then in the early 90s, the term medical family therapy emerged first in the literature by McDaniel, Hepworth, and Doherty in the text titled Medical Family Therapy, a biopsychosocial approach to families with health problems. And these authors, these researchers have continued to pioneer the medical family therapy field, and much of the information in the presentation today is from them. So over the last 3 decades, medical family therapy has expanded into its own field with distinct competencies, graduate programs, and training facilities, and has widely permeated the healthcare system. CJ Peek's model is going to be guiding the implementation structure that I propose here today. What CJ Peek's 3 worldviews are: they began as clinical, operational, and financial, and CJ Peek asserted that healthcare operations simultaneously live within these worlds, and without having success in all 3 of those realms, we can't actually have a successful integrated care system. Later on, there was added a 4th world, which is training, really for the goal of ensuring that the team is educated to execute on all 3 other realms: clinical, operational, and financial. Implementation for the clinical direction or the clinical realm of this model looks like team-based biopsychosocial spiritual approach to assessment, diagnosis, and treatment planning, as well as treatment execution. This would result in less fragmented care and thus more ease for patients and a higher likelihood of treatment success. Additionally, our hope is that it reduces burnout for the primary care physicians who really are shouldered with the brunt of mental health challenges experienced by patients, but don't always have the time or the appropriate training to address these issues. And this can cause a lot of burnout in the primary care field. And we want to take some of that pressure off of primary care physicians and spread it out amongst the team in a way that will be more effective in the clinical treatment. In terms of operational implementation for the clinical operations that we'll be moving toward, we'll want to shift towards a shared charting system. We want to make sure that staff is well educated on the appropriate coding and billing practices. What's very important is also creating a shared location of facilities where patients can go for sort of a one-stop shop. So let's say that they're coming to primary care and we notice that they are severely depressed and they may need medication, they may need therapy, and oh gosh, they also may need some family intervention because they're having a lot of relational issues with their spouse. These located in the same facility is going to eliminate a lot of struggles for this patient and probably increase the speed at which they recover, in addition to their lowering their frustration with having to kind of juggle all these different facility locations, and again, just creating that one-stop shop for their care. Additionally, with that same concept in mind, we want to create a shared online portal for patients to access their health data, schedule appointments, and access their billing documents. In terms of the financial realm, this is something that's very important, and it would be important that we as a team have an understanding of how the program is doing financially. We would also need to engage a financial specialist, such as an accountant on our team, to kind of forecast all this data and present on an annual basis to the team so that we can implement that information and make changes in the structure that might better support our financial goals. So on an annual basis, I suggest that the finance team would conduct a program cost analysis, looking at costs of the program, additionally, they would conduct a cost effectiveness analysis, looking at how effective different methods are for a given cost of our program. Additionally, cost benefit analysis. So this would be them comparing costs to outcomes. And then we'll want to also understand the return on investment that we are generating. Outcomes would then be presented with the healthcare team to explore potential updates that we can make to continue to build financial sustainability without compromising quality of care. In terms of training, some trainings that we would want to get going before even implementing the launch of our program, we would need to train everybody on the process and procedures for utilizing medical family therapists in the system. This would include understanding the updated screening and intervention protocols. We would have a training on the shared charting system, including education on common shorthand and expectations around documentation. Additionally, we would want to educate the team on delineating scope of practice and competence. This would be learning how to maintain boundaries around professional scope while interacting with a lot of cross-disciplinary data. It's essentially delineating who on the team deals with what. Since, for example, as a therapist, you may also be being briefed on things like the patient's blood pressure, which is not really part of your scope of practice. So we'll want to have really clean boundaries around who does treatment on what metrics and who is actually interacting with what data when it comes to the patients. And they may ask questions, for example, on something that is not a part of the therapist's scope of practice, and the therapist would need to refer that back to the primary care physician or someone else on the team. Additionally, some ongoing training ideas are systemic thinking in healthcare, cultural humility and implicit bias training, relational roots of pathology, and some relational models of healing. And finally, the next couple slides will talk about the screening protocol, the treatment, and potential interventions for medical family therapy as we do integrate MedFTs into the system. For the screening protocol, there may be a number of different ways that the MedFT gets engaged in the case. The primary care physician might screen a positive patient for MedFT engagement based on their standard screening protocol with use of tools such as the PHQ-9 or the GAD. If these aren't already implemented in annual checkups, I do recommend implementing simple tools that measure anxiety and depression, such as the PHQ-9 and GAD. It's a really easy way to catch patients who might not be presenting their mental health challenges in such obvious ways. The primary care physician may also notice mental health concerns that the client is not reporting through observation, maybe family member report, etc. Additionally, the patient may schedule themselves for an appointment, stating that they have mental health issues that they're concerned about, maybe anxiety, depression, substance use, etc. In any of these cases, the MedFT can be engaged for help for further assessment, diagnosis, and treatment. So once a potential mental health concern is flagged or self-identified by the patient, the MedFT will be briefed on the case and conduct further biopsychosocial spiritual assessment, including the use of screening tools to gather more data depending on symptomology. For some example, once there's a positive screen, the workflow would generally look like this from a high level. There's phase 1 is patient briefing. So the MedFT is briefed on the case and they review the chart. Phase 2 is introduction to the patient. The MedFT introduces themselves and tells the patient what MedFT is and why they're there. Phase 3 is the elicitation of the illness story, where the MedFT will conduct further screening and BPSS assessment to identify the presenting problems and goals. They'll also want to listen to the patient and help them create a coherent illness story so they understand their reason for being there. Phase 4 is intervention, which can look like many different things and may really vary based on the presenting problem and goals. But the MedFT will meet with the patient, maybe the couple or family, depending on who the unit of treatment is, and they'll conduct the intervention. In this phase, they may link the patient to additional resources. They may engage other professionals who will be a part of the treatment team, such as a psychiatrist, nutritionist, social worker, addiction specialist, etc. And they'll conduct potentially conjoint sessions with healthcare providers or family members. Phase 5 is relaying information. The patient care is going to be coordinated on an ongoing basis through communication by the team and documentation in the shared charting system. A few interventions that have been shown to be effective in primary care settings are CBT, motivational interviewing, solution-focused, brief therapy, and EMDR. Given the time that we have today, the short amount of time, I'm not going to go into each of these treatments, but I have included a reference to studies that actually were done in primary care settings with each of these models. And so you can take a look at those if you have a little more interest. Of course, as always, before applying anything wholesale, we'll want to explore whether it's context appropriate, asking questions such as, is there research that shows efficacy for people from the patient's culture, race, gender, presenting problem, etc.? Is there time for this intervention? Who is the unit of treatment? What stage of change is the patient in, etc.? So treatment planning might vary a bit for individuals, and coming from a relational standpoint, I want to propose that our ideal would be engaging the support system, going back to that goal of MedFT of communion. However, if an individual does not consent to involving their family, their caregivers, their partners, etc., then we will proceed with that individual treatment and follow the protocol that I outlined above. We would just use individual screeners and individual treatment modalities. However, if we can include the family or caregivers or partners, etc., then we'll come from a relational lens. And we may choose to use relational assessments, such as the DAS, for example. And depending on the presenting problem, the family may be a supporting role in the client's achievement of their goals. They may actually be participants in the therapy themselves. If relational distress, for example, is the primary issue. And we may utilize relational approaches. Probably more long-term models won't be appropriate in a primary care setting, such as emotionally focused therapy or other family therapy models that are more long-term based. But some theories such as EMDR and solution-focused can be approached with a relational lens. Thank you so much for your time today and for listening. I've outlined a few of the resources for information from this presentation. And now I would love to take any questions you might have.